So good morning to this morning's New Brunswick Heart Center rounds. It's my pleasure to introduce Dr. Zlatko Pozeg, our aortic surgeon here in St. John. Really joined our group in 2017, and we've asked him to talk to us today about the borderline aorta. So welcome everybody, and go for it, Zlatko.
Perfect. Thank you very much. Good to be here. These are great rounds, so I hope to contribute to it here. So yeah, I had a chat with Ansar and I thought we discussed the borderline aorta, and we'll get into exactly what we mean by the borderline aorta and go from there. I'd also draw your attention to our website, aorta.ca, for other information. I'll put the talk on there as well as the other website. So I'm going to keep it quite simple, and really would like to cover what is considered a borderline aorta and why is it considered a borderline aorta, and how do we manage it here at the New Brunswick Heart Center, or how do I view it, or how do we view it as cardiac and aortic surgeons. I always like to go back to the history. I find it just as important, if not more interesting actually, than realizing that these things have been thought about for hundreds of years and drawn and illustrated and thought about how to manage. This is a text from over 200 years ago about how to manage an aortic aneurysm and drawing ascending aortic aneurysms. I mean, of course, at that point, they only had access to post-mortem samples, but nonetheless, these are issues that have been persistent and thought about for a long time, and it's good to know where we've been, to know where we're going. And I like this quote from a non-living mentor: "There's no disease more conducive to clinical humility than aneurysm of the aorta," because I like this because I feel this every day actually when trying to make decisions about managing these patients. So what is a borderline aorta? These, I will say, are not borderline aortas. You can see very large ascending aortas, and these are quite clear. We know what to do with these. In the aortic world, what we consider to be a borderline aorta is in the range of 5 to 5.4 centimeters. As an example, you see here illustrated in the CT scan. Why is it borderline? Why do we call this borderline? And really, it boils down to the evidence. Anything above 5.5, there's pretty good and clear evidence for what we should do for the majority of cases. Under 5, the exact same is true. For cases and sizes between 5 and 5.4, there really is a significant paucity of good clinical evidence and data to know what to do. And I just do want to reiterate, we are speaking about the ascending aorta, and this comes up all the time in daily and regular conversations in the hospital about the aortic root versus the ascending aorta versus the aortic arch. Maybe one side take-home message from today is these are very different segments of the aorta. They have very different properties: hemodynamic, biomechanical, biologic, and behave very, very differently. And that's why we have different criteria for each segment. And although they're small segments, they're adjacent to each other, they're right beside each other. It's always astounding how different they actually are and behave. So we really are talking about the ascending aorta, that sort of 2 to 3 inch segment between the aortic root and the aortic arch. And maybe just another illustration that maybe that's a good talk for another day, and discussing sort of the how and why we treat each of these segments differently. But just for today's talk, we are really discussing and focusing on the ascending aorta. So why is this a problem? So it's a significant cause of morbidity and mortality in society. And really the crux of the issue is it remains largely, and for the most part, asymptomatic until a catastrophic event occurs. And we know about aortic dissections most commonly, and rupture and death. And subsequently, morbidity and mortality for these patients who present in such a way and undergo intervention the complication rate is very significantly higher than elective interventions. So that's what we're dealing with here, is managing these in the emergent dire scenario versus an elective scenario. So really, there's a very, very strong and high need for identifying and surveilling these people, and then in timely treating patients who we deem to be at a greater than normal risk. So again, who or why should we proceed, and who should get this operation of replacing the ascending aorta? As with all decisions, there are risks and benefits to both options. Certainly in elective scenario, there's intervention-related complications. Even in high volume centers, these are not negligible, including mortality, morbidity. Maybe once a year you have, I would see, you do an elective ascending in an elderly, otherwise healthy individual who has a stroke or an MI, and it can be a devastating complication. Not to mention the reintervention rate, and again, a question of what to do with the aortic valve in that scenario. Combined or balanced by the natural history of the disease and the risk of dissection, rupture, and the associated morbidity and mortality of that. So it's a very difficult scale to navigate sometimes with these patients. So size does matter in these, and really, this is it's the best tool we have now to assess risk, although it's a very one-dimensional tool. It is the best tool we have right now, and we clearly know that normal size of aortas differ across differing parts of the population, men and women, and for different body surface areas. And these are observational studies, and we know that the higher, this is a risk table based on aortic size on the horizontal axis at the top and height on the vertical axis, showing, the smaller you are and the bigger the aortic aneurysm, the higher your risk is in the red here. And I'll get into more detail on this. Clearly, there's a limit to the size of the aorta that it can take. And we currently base all our decisions on some small, old observational retrospective studies. We know that the aorta dilates in aneurysmal disease. It's an indolent but virulent process, and does continue. And there is a clear hinge point when risks increase. And these observational studies have demonstrated this to be sort of at the 5.5 to 6 region here. And you can see here at 6, the lifetime risk of dissection and rupture dramatically increases. So this is basically what we've been making, surgical decisions for patients on, based on these small retrospective studies. What I just would like to point out is that the data is okay, but not great. A lot of this data comes from the Yale Center for Thoracic Aortic Disease. And yes, we clearly know that once the aorta gets above 6 centimeters, the risk of rupture, dissection, and death dramatically increases. But clearly, there's not an insignificant amount of events that occur under 5. And the crux of the matter is, how do we identify these patients? And between 5 and 5.5. Again, showing the same thing. The risk dramatically increases as one gets above 5, 5.5 to 6 here, risk of rupture and dissection. But again, the number who occur below that threshold that we currently use is not insignificant. This is an interesting slide. It demonstrates, and this is from the International Registry of Aortic Dissection, IRAD, which looks at all dissections, including type A dissections. And this is a retrospective study of 600 patients looking at the size of the aorta at rupture. And there was a significant number of patients who ruptured with an ascending aortic dimension of under 50. So clearly, we're not capturing adequately all these patients. There's not an insignificant number of patients who present with acute dissection before the current recommended threshold for prophylactic repair is reached. And to summarize the previous slides, this accounts for about 15 to 30%, as much as 30% of patients who present with type A dissection. So size very clearly is the best we have, but it's quite a poor measurement. So this the group include. So another option we have is index size, and that is certainly a little bit better, but it's not a perfect measurement either. This group, Svensson's group, Lars Svensson at a Cleveland clinic, very big aortic center, went back and utilized aortic an index measurement utilizing aortic cross-sectional area divided by height in meters. And they went back and looked at some 600 dissections. And when they utilized this indexed measurement, they found they almost missed none, almost none. It was in the single digits number of dissections they missed if they utilized this and made 10 as their cutoff. So this index number is something we've been using more and more, and something I calculate and use almost on a daily basis in people with a borderline aorta, that is being between 5 and 5.4. And the recommended surgical threshold is it varies between 10 to 12. 10 certainly in those with connective tissue disease, and perhaps 12 in otherwise normal individuals. So clearly, I like the sentence, so I copied it directly. The aortic size criterion is valuable, and it's held up clinically to some degree as a guide for prophylactic surgical intervention. However, there's more and more evidence that traditional criteria should be revised and supplemented by non-size parameters to bring out a more multi-dimensional approach to surgical decision-making. And what are these non-size criteria? And I'd like the essence of this part. I'd like to clarify and get across is that really these are highly theoretical at this point in time, for the most part. But we do look at sex, age, family history still is an important one. If you have a primary relative who's had a sudden death or an unexplained sudden death at a young age, that's something I factor in quite heavily into making decisions. And the other thing I don't put in here as a patient factor is sort of that theme of having a ticking time bomb in your chest. In the past, we never really used to put much credence in that, but if patients feel really had a high amount of anxiety related to this, I certainly take that into consideration in making a decision in the borderline aorta. Other characteristics, and these are slowly coming out in terms of the biomechanical engineering properties of the aorta, the stiffness and compliance measurements, and there are labs that are currently working on this, but this is not practical in the clinical realm today. And certainly imaging characteristics, dynamic imaging, real-time imaging, finite element analysis of the aorta, looking at wall thickness, wall stress, location of dilatation, and these sorts of measurement that can potentially predict those at risk for rupture. Again, these are theoretical at the moment and have not entered the clinical realm, but something for the future. And biomarkers as predictors of dilatation, future dilatation, and acute aortic syndromes. Again, labs making headway in these last three categories, but not practical in today's terms in terms of making daily clinical decisions. Again, so just to reiterate again, apart from aortic size, who do I consider at risk? Again, we discussed connective tissue disorders, including Marfan's and other much more rare connective tissue disorders. Bicuspid valve is always a big one, and the level of evidence is interesting with this. We used to think that those with bicuspid valves had different biomechanical properties of the aortic wall and were more prone to rupture, and therefore the risk, the surgical threshold was decreased. Current evidence and more we're finding out that that may not necessarily be the case, and the aortic community has kind of increased their threshold for bicuspid valves and operating on them as they were a tricuspid valve. Family history I discussed. Again, first degree relative who had a sudden unexplained death is an important risk factor. And we do see people with Turner syndrome or coarctation not infrequently who, again, I anecdotally, this is anecdotal to some degree, and observational studies, who have an increased risk of rupture. So I lower my threshold in those patients. Again, so we do have guidelines for management of thoracic aortic disease that came out from our Canadian colleagues, the Canadian Journal of Cardiology, and the ACCHA guidelines, which essentially are summarized here. Clearly, we operate on aortas that are over 5.5, and that still stands. And again, the ascending aorta at greater than 5 is open to a great deal of interpretation and left up to the clinician. And this is the crux of the matter here. Um, uh, Overall, I just let you know, to summarize that part, the level of scientific evidence for the borderline aorta is extremely poor. There's no randomized data. There's only small retrospective studies and consensus opinions. And it leaves lots of room for flexible interpretation, as I said, including patient preference, aortic shape, rate of growth, patient size, other clinical characteristics of the patient, and so on. So uh, one of our Canadian colleagues did this large systematic review looking at the association of mortality and acute events with ascending aortic aneurysms. Thousands and 10,000 patients, thousands of studies demonstrating that the growth rate of the ascending aorta is there, but is slow, and the risk of dissection, rupture, and death may be lower than previously understood. And this really prompted the thought of the need for a randomized controlled trial. And really, there's no reason we can't do this. And we look to our colleagues in the vascular world who have done an excellent job in really managing the abdominal aortic aneurysm situation, whereby they have done randomized controlled trials and have clearly delineated that, and this is from one of our aortic specialists, that are siblings in vascular medicine surgery who have in fact done so and shown that for abdominal aortic aneurysm smaller than 55, the risk of early surgery outweighs the risk of rupture during surveillance. And really, there's no reason we can't do this for the ascending aorta and do a randomized controlled trial. So this has prompted sort of a landmark randomized controlled trial that was initiated by some Canadian colleagues. I'd just like to point out this survey that was recently done as well, looking at cardiac specialists, 700 international cardiac specialists, surgeons, vascular surgeons, cardiologists, asking this question. Recognizing each patient is different, what is your usual threshold for recommending surgical intervention for an asymptomatic adult patient with an incidental finding of an ascending aortic aneurysm, all things being equal? And there's very interesting, clear clinical equipoise. 50% of respondents would offer surgery at a threshold smaller than current guidelines recommend at 5 or less, and 50 would respond at greater than 44 at greater than 5.5. So really the interesting clinical equipoise, and there is no clear consensus here. Follow-up question to that was which one of the following criteria would most cause you to consider altering your usual surgical threshold? And greater than 80% of respondents would alter the surgical threshold based on a patient factor, such as bicuspid aortic valve, BSA, age, and gender. So clearly, some more guidelines are needed here. So this has prompted this randomized controlled trial, which I'd like to just introduce because we've been asked to be a part of it, which is a wonderful thing. So this study called Titan, Treatment in Thoracic Aortic Aneurysm Surgery versus Surveillance. And these are actually, it's a randomized controlled trial, an international trial looking at those with a borderline aorta and randomizing them to surgery versus surveillance, and looking at the primary outcome of impact of early surgery on all-cause mortality. So it's a multi-center randomized study of surgery versus surveillance for the 5 to 5.4 aneurysms. And we've been a part of this, asked to be a part of this, which is an excellent thing for us. And we've the research team has done an excellent job in getting this up and running, Carol and others. And we've already randomized several patients in this study. So this will be a landmark study and will help us in making decisions for these patients. So what have we learned today about the borderline aorta? I'd just like to summarize some take-home messages here. Clearly over 5.5 at this stage we operate. There's very poor to no data for the 5 to 5.4 centimeter aorta. Guidelines really are not helpful. And really we're flying by the seat of our pants in this range based on our clinical experience, taking into account ancillary patient factors. And we do okay, but we don't do great. Indexing is not perfect, but its use in the borderline aorta can be useful. And really it's the best tool we have as we await other more sophisticated tools to help us evaluate the risk profile of these borderline aortas. And now we are part of this landmark international randomized controlled trial that's ongoing that will help us better make these decisions. Thank you.
Excellent, Zlatko. Thank you very much. And it's now open for questions. We've got some questions from the audience. The first starting is if you could stop sharing your screen, then we'll be able to see. Yeah, perfect. So Craig is asking, Dr. Craig Brown, in a redo situation, do you use the regular guidelines?
Now we're getting it from murky waters to very murky waters. I don't know. My thresholds tend to be a little bit higher. One, because the risk profile of the surgery is increased. So you can't, really it's the reason we operate on 5.5 is because the risk of rupture is so much higher than risk of surgery. But if you're elevating that risk of surgery from now 2 to 6% or 8%, then that balance is a little more even. So really, patient factors play into it even more at that point. Certainly, if they're above 6, then I almost always do. If they're I think the borderline is then shifted from 5.5 to 6 in the redo setting. So everything just shifts a little bit in that setting. So I generally wait till 6 in the redo setting.
I have a question, Zlatko, around surveillance and not about what we should do for surveillance, but is there any evidence out there on surveillance and frequency and all of that? And do you think there'll ever be evidence? It's one of those black boxes in my mind that
You mean in terms of?
how often should you do CT in somebody with a borderline? You know, does anybody know? It doesn't matter, you know, that kind of.
No, none of that's been borne out really in any data. Again, all this data is very observational, retrospective. We've been doing it on an annual basis, and sometimes I do think that's too often. Maybe we don't need to do it annually. Maybe 18 months is enough. I just don't know the answer. And sometimes you just get a sort of an overall gestalt of the aorta and you feel this is one I need to watch a little bit more. This one seems stable to me. And again, that's not really a great way to practice medicine in the long term, so we do need better guidelines for that. There's no guidelines as far as I know for surveillance.
So now along the same line, so there's a question. I'll bring the question to David Marr. At what level do you wish to see these patients referred to you? I know you've set up some guidelines at the Heart Center for referrals, so perhaps it's a good opportunity to sort of talk a little bit of.
Yeah, generally, and we get a lot of these referrals, and rightly so, as we should. We get a lot in the 4s, 4.4, 4.3, 4.5, and that's reasonable. And I think we should initially assess these people. I generally keep them under our umbrella once they're over 4.8 or so, and that's in my mind when these patient factors start to become significant. If they're under 4.8, I do we generally send a letter back saying, maybe if you could consider doing an annual CT at these people, and then send them back once they're 4.8. So generally around 4.8, David, is when we would have these patients referred and kept under our umbrella, and that's when you're in the margin of error measurement. One person's 4.8 could easily be my 5.1 when I measure. So.
Yeah, so you bring two important points there. Is not everybody reviews the CT the same way, so there is variability there, and that's why it's important for three-dimensional reconstruction, looking at all dimensions in a proper way, not tangential.
Absolutely. Yes.
And then, so a question from Peter, which is good, and then a question from Chris. The question from Peter is around blood pressure management, and maybe you can sort of elaborate a little bit on, there is some old trial data on beta blockers and ARBs, but it's one of those things. How aggressive should we be? Is there a role here? And how do we manage these things?
So this is a very big discussion with every patient, and blood pressure is by far the biggest thing they can do to alter the natural history, and it markedly alters their natural history. And I find it ends up being too much of a discussion into what agent, how, and I always send strongly worded letters out to primary care physicians that it doesn't matter how you get the blood pressure down. Get it down by whatever means you are comfortable doing so. And I initially say aim for somewhere in the 120s. Under 120 or 1 teens consistently is what your goal should be. And I tell every patient should get a home blood pressure monitor. It's a very, very low cost way that can catch something very, very important. And most people do, and they don't get a one-time measurement in a doctor's office. So they measure it at home consistently, same time of the day. But I think the most important message is don't worry about type of agent. Get it down by whatever means you are comfortable getting it down. That is the most important point.
Great advice.
Yeah.
Question from Chris. Great talk. What about patients that require other surgeries? So they go for their CABG, or they go for the aortic valve, or their mitral. Do you sort of use a different threshold in that time?
I do, and I use multiple patient. I have got sort of a multi-pronged approach. So patient factors, aortic dimension, and then often I make the final decision in the operating room because you're going to be there anyways, and you can tell the quality aorta once you're there, and look and see how big it is. So you do have that advantage of that third piece of data. So, but I generally go in knowing that if an aorta is over 4.5 to 5, and I'm there for another reason, I would likely replace it. If they're an elderly patient who have other comorbidities and you're there for a coronary, I may leave a 4.5 alone, probably not a 5. If they have a bicuspid valve, I'll almost always replace a 4.5 aorta.
Excellent. So for our last question, a very important one also is around the strong family history of dissection or aneurysm without a clear genetic component. So how do you follow the family members? And how do you follow the ones that have a normal aorta?
Well, that's great question. And this is something we're going to try and continue to work on here, is the genetic component. And I actually am seeing more and more people with potential familial history, not an outright, obvious Marfan syndrome situation, but familial history. So I do ask about all that. And my first step is to ensure they have their own family physicians. I don't see everyone at that point, but I do ensure they have a family physician. They alert their family physician to the family history, and they should all have a screening echo to start with at some point to document their aortic size by echo. And then guidelines from there are not clear. And maybe every 2-year echo or something at that point would be reasonable. But then I only use the echo as a guide to a CT. I don't go to a CT at that point. So I do counsel them to some degree and leave the ball in their court to some degree. So I don't see all the primary relatives yet, but I do ensure that they should have counsel them that they have a family doctor, see their family doctor, tell them about the family history, and probably should get a screening echo to start.
Okay. Anyways, this was an excellent talk, Psycho. We're at 8:30 right now. Thank you everybody for joining this morning, and we will be posting the recording of this on our YouTube channel. Thank you everybody. Have a good day.
Thank you.